Mr. Chairman, ladies and gentlemen, it's my pleasure to be here and to speak about ultra-protective strategies. So first, I wondered when I got this topic, what is protective ventilation in severe ARDS? Is it really defined? I think every one of us is using as protective ventilation and is calling it protective ventilation when he is using small tidal volumes around 6 ml per kilo predicted body weight. That's fine. I think that's true. That's part of it. Protective mechanical ventilation is more, I believe. It's to keep the pressure, especially the peak pressure, the airway pressure, plateau airway pressure below 28 or 30. But then we have to use in addition PEEP. What is the best PEEP when we are using protective ventilation? What is about muscle relaxation? Is this also protective ventilation? I think at present it's not very well defined, and it might differ from person to person. And when the first study was published, the first several studies were published, Aishaka and co-workers performed a meta-analysis of all the different studies. And they analyzed these 5 studies, and clearly the ARDS network study was the biggest one. And they found, okay, there were 2 beneficial trials showing that low tidal volume caused a benefit in the patient. And there were also 3 non-beneficial trials where in that setting they used the low tidal volume caused more harm than benefit in the patient. And in this paper, they speculated that it might be in that way that in some patients we have an optimum, or in every patient we might have an optimum with the tidal volume and with the resulting plateau airway pressure around here. Whatever around here is, I can't define it. This may vary between patient and patient. This may vary between moderate ARDS and severe ARDS. This might depend on the degree of the severe ARDS, whether it's non-pulmonary or pulmonary ARDS. No one can say this, how in the individualized patient the best tidal volume should be and what's the best plateau airway pressure in this patient. But what we know is that if we are increasing the tidal volume in general towards 12 ml per kilo predicted body weight, then it's clearly causing harm. And the authors at that time point already believed that if we are decreasing the tidal volume too much, that in this case we will also cause harm in the patient. In our lab, we analyzed this effect, what is the best tidal volume. We hypothesized that we could reduce in the animals, in swine, the tidal volume to 3 ml per kilo in combination with interventional lung assist to eliminate the CO2, and compared that to a control group where the animals were ventilated with a tidal volume of 6 ml per kilo. And this was done in an animal model where we induced the ARDS by repeated lung lavage so that the PaO2, FiO2 remained for more than 1 hour after the last lavage below 100 millimeters of mercury. What we found is that doing that for 24 hours, that after 24 hours, the animals treated with the low tidal volume in combination with the lung assist had a higher, really increase actually in interpulmonary shunt compared to the animals treated with conventional mechanical ventilation with a tidal volume of 6. These animals had nearly a normal shunt value. However, these animals did not really reduce their shunt volume. So we believe that in this setting, we had several problems. we had to realize that there was not a difference in gastric, that there was not an improvement in gas exchange, but we had also no difference in the different organ injuries. However, ventilation with a tidal volume below 6 ml of milliliter per kilo of body weight caused clearly a de-recruitment in this setting where we used a lung lavage model and used only a moderate PEEP of 5 centimeters of water. So I believe that our animal model was not good enough and not near to the clinical setting to show that there might be a benefit when we are decreasing in some of our patients our tidal volume below 6 ml per kilo predicted body weight. Then, in the same year, Teagni and co-workers published a very nice study. They believed that, again, the 6 ml per kilo and the plateau pressure below 30 centimeters of water should be individualized. They said, we don't believe that every size, as Daniel showed, is fitting for everyone. And they said, okay, there might be some patient that will show a hyperinflation if I'm using the low tidal volume of 6 ml and keep my plateau pressure below 30 centimeters of water. And for that study, they used CT scans, and here is one CT scan of a patient with ARDS, and this is an end inspiratory, that is end expiratory, and they analyzed where the inflation is going to, in which lung areas the inflation is going to. And here is the histogram they used, and clearly it was shown that the air is going to lung units with Hownford units below, between minus 500 and minus 900. And here this is a good way to ventilate a patient. The air is going in that area where we need the air. But in this other case, here is clearly a more severe ARDS. Also in end expiratory and inspiratory, we have high volumes of atelectasis. And in this case, the inflation is going in the already overinflated lung areas, and there the tidal volume is causing damage in the patients. So what they did these analyses in 30 patients with ARDS during expiration and inspiration, and they found that in 20 patients, in 2/3 of the patient, this ventilation mode was quite well. The inflation went to about 70% into normal lung areas and only in about 8% to already hyperinflated lung areas. However, in 1/3 of our patients, 1/3, this is a huge amount, 1/3 of the patient, the tidal volume of 6 ml per kilo went only to a smaller part in normal lung areas and to the major part in already hyperinflated lung areas. And analyzing this, what are the factors? They could not identify clearly a cutoff values for the PaO2, FiO2 values. The mean values were slightly different, so you can say, okay, the less protective subpopulation was a population with more severe ARDS. The plateau pressures were clearly increased from the protected subpopulation, where the tidal volume of 6 ml per kilo was fine, in comparison to the less protected subpopulation, where the plateau pressure was around 29. And they used also, due to the severity of the patients, a slightly higher PEEP in the less protected subpopulation. And they could show that at least there was a trend towards a higher mortality in the less protected subpopulation group. And consequently, they performed a second study, and in the second study, they again had 32 patients with ARDS, and most of the patients, 2/3 of the patients, showed a plateau pressure between 25 and 28, and these patients were treated conventionally. But about 10 patients showed a plateau pressure between 28 and below 30 or equal 30, and these were, in their eyes, the patients who should be treated in a more protective way. And in this group of patients, they tried to achieve the plateau pressure between 25 and 28, and for that they used the extracorporeal CO2 removal device. So with a low flow extracorporeal CO2 removal device, with the flow rate between 300 and 400 mL, they tried to ventilate these patients in a more protective way. And they could clearly demonstrate that when they entered the study, the patient, that the well-ventilated and well-protected population showed that the inflation was going to 72% into the normal lung areas and only to a smaller portion of 4% into the already hyperinflated area. However, after 72 hours, this was even improved in this patient population, which was well protected. In the other group, in the less protected group, the tidal volume before they started the extracorporeal lung assist, the inflation went only to 40% in not in hyperinflated lung areas, but in 20% it went directly in hyperinflated lung areas. And performing the extracorporeal CO2 removal, they could improve this relation significantly within the next 72 hours. So they used a small blood flow to eliminate the CO2, and they had only a few complications during the assist. And they could also clearly show that within the 72 hours, the pro-inflammatory response, which was really elevated during at the start of the study in the less protected group, was reduced to nearly normal values, and this was true for EL6 as also for EL8. So Gattinoni 2 years ago stated that clearly we have, within the framework of protective strategy, we have to apply approaches where we assess also the stress, strain, and the lung volumes. And he said that it might be possible that in the near future ECMO could be applied at the earliest stage and not as a last resort. We have heard already that also it seems, at least in that way, the two studies with high-frequency oscillation were performed, that this is not a mode to perform adequate ultra-protective ventilation strategy. Slutsky 2 years ago showed a nice slide in his review article in the Journal of Clinical Investigation, where he stated that if we are causing in an already injured alveoli a high stretch ventilation, then it will increase the pulmonary edema. And if we are using a low stretch ventilation, it will reduce the pulmonary edema. And he and Slutsky and Ranieri, they demonstrated in a review a few months ago in the New England Journal that, again, if we ventilate a patient with ARDS with really too low a lung volume, then it will cause lung inhomogeneity and it will cause atelectasis. On the other hand, if we are using high lung volume, then it will cause hyperinflation and overdistension. And if we have that we have overdistension or atelectasis, this both will cause structural consequences with hyaline membranes, with pulmonary edema, with increased alveolar capillary permeability, with fibroproliferation, with surfactant dysfunction, and so on. So he believes that in order to avoid these biological alterations and physiological abnormalities with the consecutive systemic effects, which will finally end up in multiple organ dysfunction and death, that we should use a protective ventilation strategy. And he is again explaining how the lung volume and transpulmonary pressure are linked together. And he is stating and giving explanation again for the pressures we have in our lung and in the pleural space when breathing spontaneously. And clearly, when we are breathing spontaneously, the alveolar pressure is 0, and the pleural pressure is negative. It's -8, around -8 when we are inhaling. So the transpulmonary pressure is 8 centimeters of water. If we are ventilating a normal patient in the OR without any acute lung disease, then the pulmonary pressure is, the alveolar pressure is around 9 centimeters of water. The pleural pressure is slightly positive, and this again ends up with the same transpulmonary pressure. If a patient has a stiff chest wall and is mechanically ventilated, then we will find a high alveolar pressure at the end of the inspiration, but we have also a high pleural pressure. And this again will cause low or nearly normal transpulmonary pressure. If we have a trumpet player who is playing a note, then we will have a high alveolar pressure of 150 centimeters of water, but at the same time, the pleural pressure is 140 centimeters, and again, the transpulmonary pressure is the same. But if we have a patient with respiratory distress, and he is spontaneously breathing, then he will cause a negative pleural pressure. The alveolar pressure will, due to the mechanical ventilation, positive, and then we have a high transpulmonary pressure, and this will cause harm in the patients. So this might actually be the effect why this study from Papazian was so positively. He used the neuromuscular blockers in early ARDS. He used cis-atracurium, and he could clearly demonstrate that there was a trend towards a 90-day survival increase with the use of cis-atracurium, and analyzing especially the group of patients for the first 28 days, he could find a positive effect with respect to a number of ventilator-free days, and analyzing the 90 days survival. This was nearly, this was clearly trend towards survival improvement. However, if you analyze the subgroup of patients with a PaO2 of FR2 of below 120, there he had clearly a beneficial effect. And these are the patients who are more severely damaged due to their disease, and this is again the individualization we have to perform in our patients. So I don't believe that we use neuromuscular blockers in all of our patients, but in the most severe diseased patients. So would this be a help to use extracorporeal CO2 removal in the normal patient? In the normal patient with ARDS, with a PaO2 FiO2 ratio below 200. This study was performed in Germany by my colleague Thomas Bein. This was a multi-center study. We participated in this study, and we included only 79 patients in this study. We had several problems to include the patient because of the fact that we wanted to use extracorporeal lung support with CO2 removal in an early stage, and a lot of these patients we screened. During the clinic process, they already didn't fulfill any longer the inclusion criteria. We often found an improvement within several hours, and some of the patients showed deterioration. They came on veno-venous ECMO, and 4 patients had to be excluded due to death, and from 5 patients we didn't get informed consent. But these 79 patients were randomized, and 40 patients received a tidal volume of 3 ml, and the PEEP was used according to the ARDS network table, and in the other group it was nearly the same. However, the tidal volume was 6 ml per kilo ideal body weight. In this group we used extracorporeal CO2 removal. We couldn't find any difference in mortality in the whole population, no difference in days of mechanical ventilation and ICU. So in general, it seems that this is not the right way to do it. So in moderate ARDS, we shouldn't use this approach. However, again, analyzing the patient population who was more severely damaged by the disease with a PF ratio below 150 millimeters of mercury, there we found a significant effect of the low tidal volume, of the ultra-low tidal volume of 3 ml in combination with extracorporeal CO2 removal in comparison to the conventional approach. So this might be something we have and we can evaluate further on, but clearly we have to individualize our approaches, and we have to perform individualized studies, RCTs, in order to find the best way to treat the patient. So to sum up, I think nowadays lung protective ventilation is obligatory in any ventilated patient, and that is true also, in my opinion, for the OR. So everyone should start with protective ventilation. I'm not convinced that every patient is having a benefit from this, but I do not believe that we harm patients when we are using 6 ml, for example, in the OR or in the early phase of postoperative treatment in the ICU where the patient is still ventilated for 2 or 3 further hours. I think also there lung protective mechanical ventilation should be used. Means of ultra-protective mechanical ventilation could be 3 to 5 ml per kilo tidal volume of predicted body weight. It could be that we should use relaxation, but I'm not completely convinced. Maybe we could also achieve the same effect when using a deep sedation in severe ARDS to avoid or to minimize spontaneous ventilation within the first 48 hours of ARDS. And I believe that ultra-protective ventilation can be enabled by using either permissive hypercapnia with pH values higher than 7.2, or in combination with low-flow extracorporeal CO2 removal. Many thanks for your attention.